on how to interpret, how to read these ECGs. So ECG interpretation. Again, unfortunately, we're not in a face-to-face lab. If we were in a face-to-face lab, we would actually be able to hook up some poor soul there in lab. In lab, we wouldn't do the entire 12 lead. Right? Let me back up a little bit. There are two ways to conduct an ECG, right? Electrocardiogram. So the simplest and effective is what we call the 3 lead. The more elaborate, more detailed information would be the 12 lead. Right? So this is just kind of a picture. This is the fundamental concept behind a 3 lead sort of ECG, right? So we can have an electrode, electrode, electrode. And realistically, they would be placed on actually on the wrists and on the ankle, right? And what we're trying to do, we're trying to make like a triangle, right? In a lab setting, we don't want to be too invasive. So, I mean, most people have exposed wrists and maybe just pull the pant leg up to expose the leg. In a hospital setting, again, you sign consent and this kind of stuff. So they can be a little bit more invasive. On a 12 lead, you do have to kind of get up and intimate with the individual. And again, we wouldn't do the 12 lead in lab. We would do the simple 3 lead. But we're trying to generate a triangle. And I'll show you another picture of that very shortly. We're trying to get then a view of the deflection waves, the depolarization waves, the P, the Q, the R, the S, the T waves, right? So again, we're looking at the sort of location for the right atrium, right, sort of basically the right atrium, left atrium, and then the lower leads down here. So these ventricular leads going sort of wrapping around the body there. So the concept, and again, this goes into some physics. Remember what the ECG is trying to show is the composite, all of the electrical activity happening within the heart, the conduction system, and the myocardium, right? So somebody much smarter than me came up with this sort of mathematical and technological sort of invention. We call this the Eindhoven triangle, this concept of sort of analyzing. We can analyze sort of horizontally, diagonally back this way. So we get different perspectives of that electrical signal. So the 3 leads that we actually analyze, lead 1, lead 2, and lead 3, right? They give us information on different parts of the heart. We can actually mathematically derive the other leads, right, to generate the 12 readouts, right? So I'm not going to get into all the discussion, but they're calculated as follows: AVL, AVF, and AVR, right? So there's their AVR, AVL, and AVF. So these are mathematical composites, right? They're the composites of all this electrical activity going all over the place. For 90% of the cases, we work with lead 2, right? Lead 2 is basically kind of looking at this trajectory, this angle, which is pretty close to the angle that we're going to see from right atrium down to the apex of the heart. So again, for most cases, for introductory classes, for 90% of the situations, we analyze lead 2. If you go to a cardiologist that's looking at more intricate heart issues, then they start looking at some of the other leads and those readouts as well. But for us today, for the semester, we're going to focus on the simple information provided by lead 2. So lead 2, the one we're going to be focusing on the most. We do a 12 lead, and this is the information that we're provided. So we see, why do they call it a 12 lead? Well, we have 1, 2, 3, the 3 leads that are actually part of the triangle, the Eindhoven triangle. Then we have these other leads that are calculations, right? So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, and 12. So the 12 lead. Again, all of these provide information. The one that gives us the sort of the best view of the common waves, analyzing the trajectory from atria to ventricle, would be lead 2. So this is that little part, a little section in time that we're going to focus on, lead 2. Lead 2, and if you notice down here, this is lead 2 rhythm strip. So these are just short sections in time. This rhythm strip is a longer 10-second strip, and they can be longer depending on how the cardiologist is going to work, how much time he wants to analyze. But this printout, always when we do rhythm strip, or when we do ECG analyses, I want you to focus on the lead 2 rhythm strip. And standardly, it's on the very bottom. So this is an extension, that bottom rhythm strip is an extension of this little section here, right? So again, we can kind of see a little bit of what's going on. It's not as pretty as the book and the notes, very clear, defined waves. This is an actual ECG. Again, we can make sense of our R spike. And we got some stuff going on. A little P, very deep Q, R, S, kind of hard to see a T. So there's a couple of things going on here in this patient. But again, for us, for your homework, for the lab itself, focus on lead 2 on the sort of left side, and that extension of lead 2, which is that 10-second rhythm strip down below. So same thing, just different brand of paper, different company. Our composite 12 lead, right? Lead 1, 2, 3, the calculated AVRs, the V1 through V6 leads, right? 12 leads. We analyze lead 2, this little sort of 2-3 second little interval, and same thing, rhythm 2, except we have the entire 10-second strip there. This ECG looks a lot cleaner. Little P wave, Q, R, S, T, very minimal P, Q, R, S, T. So again, the rhythm strip of 2. Right? So this is how you would attack your ECG problems here. One last one, looking at, again, the 12 lead, lead 1, lead 2, lead 3. Our AVR, AVL, AVF, the calculated, and then the ventricular leads over here. Our rhythm strip at the bottom, 10-second rhythm strip. If you haven't watched that other video, the one that teaches you how to calculate heart rate, right? We look at the little boxes here, right? Little boxes are important, and it's very hard to see, but there's little boxes within these bigger boxes, right? So when you start analyzing these ECGs, I encourage you get a little ruler, get your little brother, little sister's ruler, something like that, and these little clear plastic rulers work really well, that you can sort of put over the ECG and calculate stuff there. Right? So our ECGs. So again, looking at lead 2. Lead 2 is our standard view. It's our angle that goes in that trajectory. So it provides the best view of the P waves and the R waves. So at the same given time, lead 2 gives us that very typical P, Q, R, S, T wave, right? That's what we would see on lead 2. At the same heartbeat, same cardiac cycle, this is what lead 1 would give us. And this is what lead 3 would give us. Lead AVR would give us. Kind of hard. It's almost reversed, right? It's going in a different angle. So again, we're looking then at the lead 2 all the time. It gives us that very positive R spike, and most useful for detecting problems that we're going to address in this class here. So I give you these homework problems. I tried to scan them as best I could. They don't come out very well. I'm sorry they didn't come out so great, but basically I would like for you to try to sort of look at these as case one. So case one is a 29-year-old healthy man. So there's lead one, lead two, lead three, and there's our rhythm strip down below, right? So analyze case one. I would like for you to be able to calculate the heart rate. I would like for you to tell me if it's rhythmic or arrhythmic. I would like for you to tell me if it's a normal ECG or does it seem like there's some sort of problem there. So see what you can do with case one. Case two. So again, our lead two are basically our situation there. Our lead three, our rhythm strip, and one moment here. So our lead one, our lead two, our lead three, and then our rhythm strip. So our 25-year-old junior doctor, which is basically a, we would assume he's healthy. We would assume that he is sort of being able to take care of himself, something like that. But we would like to see, again, the heart rate, the, let's look at the rhythmic or arrhythmic situation, and if there is any type of abnormality there, right? Case two. Case 22, we have a 24-year-old lady, previously well with 6 hours of palpitations. And so we start to see some different situations here. So our lead two rhythm strip down below. See what you can come up with. What's going on with this 24-year-old lady on case 22. Normal blood pressure, but palpitations. So see what you can come up with there. Case 27, we have a 60-year-old man with a pain, chest pain, loss of consciousness. So again, we have case, or I should say one, lead two, lead three. So our lead two rhythm strip, see if we can figure out what's going on there. Case 42, a 22-year-old lady with a history of poor exercise tolerance. So 1, 2, 3. There's our rhythm strip for 2. So see what you can come up with there. Case 58, a 78-year-old lady with chest pain and collapse, blood pressure quite low. Should be 120/80. Here we're at about half of that, so 60/40. So low blood pressure, sort of old lady, chest pains. Can we figure out what's happening with these here? Yeah. So case 58. And then case 64, again, very defined R spikes, lead to rhythm strip down below. Can we figure out what's happening with this individual? A 25-year-old male soccer player with an ejection systolic murmur. Right? So a couple of things to consider there for case 64. So again, that will conclude this discussion on ECGs. So basically see what you can come up with. Again, heart rate, rhythmic, not rhythmic. Let's see if we can come up with a guess, an estimate as to what medical problem or what non-medical problem that person is dealing with it, right? So that will be your lab assignment. I'll let you work on that for a little while. I'll give you further instructions a little bit later, and we'll go over the actual sort of answers, but I want you to have like a first guess. Before I give you the answers, I would like for you to tell me, I think this is the heart rate, and I think this is the diagnosis for this patient. And we're going to see how close or how way off you were on your diagnostics here. Yeah. Alrighty. So let me get out of here. And I hope that's useful.